Okay, but if you are still ready to come in, I guess. Okay, hi. I was in Houston for the bicentenary. That's 49 years ago. Uh, there was a bunch of us there doing jobs to try and pay our way through college. And Houston had just opened up what it claimed was the biggest, well, the highest, steepest Big Dipper in the universe. And one of the gangs said, hey, look, we should take a bicentenary ride on this. I had never been on any kind of dipper before. I was paired with a guy called Greg, who was the coolest dude that I knew, who had been on dippers before. And when the thing began to take off, he turned to me and said, when we get to the top of this, you're going to be petrified. When we got to the top, I had a moment where I looked down and said, we're dead. And I haven't recovered a memory of what happened after that. This talk is going to be a dipper talk. You're going to get a jolt or two, but nothing like the jolt Kim Witzak had, and Kim is here, when her husband, Woody, who's there with her, took a ride on a Zoloft dipper. Woody had no mental health problems before that. He just moved into a new job that he was keen to be in. He had a few nights poor sleep, and his doctor put him on Zoloft, and Woody ended up dead. Now, why I'm saying that is this talk, as I say, is going to be a dipper, but I don't want you guys to have a near-death experience like the one I had in Houston. I want you to be able to get off the ride and come up with some ideas about how to try to keep us all safe if we take any of these pills. Because we've been having problems for 50 years or more with them, and we don't seem to be getting any better at keeping us safe. So we need some fresh thinking from you guys. And hopefully I hope you're going to conceive of something new that people like Kim and I and David haven't been thinking about. I use the word conceive because today is 9 months to the day to the 250th anniversary of the Declaration of Independence. So at the end of the talk, I'm going to be throwing things over to you. Oh, no, I meant, can we go back a slide? Yeah, I'm going to leave that there for the moment because Woody and Kim are going to come up throughout the talk. David mentioned a few different trials which compared CBT with drugs. I'm going to mention one as well, which is this was done by the NIMH during the 1980s, and it compared imipramine, the first of the antidepressants, to CBT, which is a new kid on the block then, and interpersonal therapy, which is also a new kid on the block. And they figured they had to have a placebo pill to control for the drug pill and a placebo relationship to control for the psychotherapies. And the result at the end of the day was that CBT and IPT didn't beat relationships. Imipramine in severe cases did appear to beat relationship stroke placebos, but only in severe cases. And as you've heard from David, CBT seemed less likely to be linked to people relapsing than the antidepressant did. Now, you need to know that imipramine is a much stronger antidepressant than any SSRIs and less likely to cause relapse than any SSRIs. It can cause relapse, but the SSRIs are much worse. So SSRIs, which hadn't come on the market at that point, would have failed miserably in this study. Now, where does that leave us? Well, if CBT meant you were less likely to relapse, but you didn't beat relationships in the first instance, it kind of suggests, all things being equal, we should try and avoid pills and skills. that we get better on our own in usually 12 to 16 weeks on average, and maybe if we're told that, and we just try to get better on our own, or if we care for each other, maybe that's the best way forward. Now, you may say to me, well, no, I'd agree if you were to say to me that, well, at least CBT doesn't harm you the way pills do. And that's true, but let's look at this a little bit more closely. In the case of the SSRI group of drugs, they say to you that there's problems with your serotonin system, that you've got a chemical imbalance. You've got a broken brain, and our treatment aims at putting this right. Well, there's never any evidence for anything wrong with the serotonin system in people who are depressed or with any nervous problem. When you go on the pills, you're going to have an abnormal serotonin system that may never come right. But CBT and IBT and things like this are a little bit the same as well. CBT and IBT tell you you've got a broken mind. You're illogical, or you're not relating to people all that well. One of the interesting features about the NIMH study was that the people with the least cognitive distortions to begin with did best with CBT. The people who had the least interpersonal problems to begin with did best with interpersonal therapy. So there's something funny going on, and the efforts of therapists to correct our cognitive distortions, our interpersonal skills, may be making us abnormal in a way that we weren't abnormal before they began. Is this an issue? Well, to some extent it is, because a lot of the problems that are going to make you distressed and unhappy and miserable are political problems. And whether we try to solve them by giving you pills or teaching you skills locates the problem in you, when that may not be a good idea. Across medicine, across healthcare, 9 in 10 of the interventions that we get are for political problems in essence, and not for a defect in you. So, and there's a little bit of poetry to quote to you from, it's a poem called Kubla Khan, and it says, beware, beware, his flashing eyes, his floating hair, weave a circle around him thrice, and close your eyes with holy dread, for he hath fed on honeydew and drank the milk of paradise. This talk is about trying to identify what the milk of paradise is that people in healthcare are drinking that should make you wary about them. So you may say to me, that's all very airy-fairy. SSRIs can cause people to commit suicide, can cause people to commit homicide. You can get hooked to them and may never be able to get off them. They can interfere with your ability to make love. Even after you've come off them for the rest of your life, you may never be able to make love again. And CBT and interpersonal therapy don't do this well. Cognitive therapists, when the CBT doesn't work all that well, they add in ACT or DBT or IPT, and then they refer you on to people like me, who gives you SSRIs which make you suicidal and homicidal, et cetera, et cetera, et cetera. So the other point, though, is this. During the 1980s, 1990s, when the NIMH trial was actually happening, cognitive therapists were recovering memories of abuse that never happened. They destroyed thousands of families. People ended up in jail who oughtn't to have ended up in jail. They caused awful other problems. For instance, if you've got a patient who the therapist believes, you've got to believe what the patient says, and the patient's saying, I was abused on an alien spaceship at the age of 1, that's not going to help the patient's sanity. It's not going to help teamwork if that psychologist, and I'm thinking of one who is a wonderful woman, who I highly regarded up to this point, if she's saying to me, I've got to believe the patient was sexually abused on an alien spaceship at the age of 1, that's not going to help teamwork either. So there's a bunch of different problems going on here. And there's an interesting relationship. David elegantly dissected out what the pills do and what the skills do and things like that. But he's missing something about real life here, which is we get these things from doctors and therapists. And if Woody Witzak, who'd been put on Zoloft, a potent SSRI, had been given or took chlorpheniramine, a potent SSRI, which could cause you to commit suicide or homicide, wipe out your ability to make love, leave you hooked to it. If he'd taken that, Woody would be alive today. Why? Chlorpheniramine is available over the counter. And if it doesn't suit you, you stop it after 2 or 3 days. You control the situation. If you go to a therapist or a doctor, you lose an element of control. Woody's doctor told him to keep on taking Zoloft because it takes 5 or 6 weeks or more to work. This is what killed Woody, not just the SSRI. What we've got is a situation where I need to get on the intercom or the phone or whatever it is and say, Houston, we have a problem. We have a practice problem. Now, there's more to it than that. Let me just quickly make sure that I'm not losing my train of thought here. Oh, yeah. David mentioned work by Eric Turner and the fact that there was a bunch of studies that had been negative that were published as positive. Essentially, all of the literature on controlled trials in children with these drugs was negative and published as positive. The most famous study is one called Study 329, which looked at Paxil given to teenagers who were depressed. That was published as glowingly positive and no real problems. Well, it turns out that it was fraudulent. The company knew that the study was negative and that there were serious problems with it. This led to a fraud charge. It led to a $3 billion fine. And it's a wonderful, well, beyond that, despite the $3 billion fine, this is a study that's still unretracted. It's still sitting there in the academic literature as though it's a perfectly good study. It's still being built into the standards of care. It's a symbol of what you have to suspect is true of all of the medical literature with all drugs, not just mental health drugs. FDA may know that it's negative. FDA aren't going to let you know if they know that it's negative. So that's pretty grim, and part of it happens because in the medical field, academics don't write their own articles, at least not when they're involved in a company study. They've got ghostwriters. And psychologists, unfortunately, don't have ghostwriters. But I held a grant for cognitive therapy of delusions 30 years ago, and we had 2 big names in the CBT field on the grant, and we were using rating scales to see could we actually produce a change. And on the rating scales, we did produce a change. We wrote a paper saying CBT can be beneficial to people who've got psychosis, to people who are deluded. These are very severe cases. It's very clear that in the real world, the benefit wasn't really there and wasn't sustained. And I said to the gurus, we need to write this up as well. And they said, no. There's a ton of the psychotherapy literature out there that remains unpublished. There's a ton of the transcranial magnetic stimulation literature or other neuromodulatory treatments for mood disorders that remain unpublished. And it's usually what happens is when therapists or other people treating you take on severe cases and find their pet treatment out of which they're going to make money doesn't work for the severe cases, that's what doesn't get published. What gets published is the kind of stuff that keeps our wellness industry going. Now, A little bit of what's going on here is, well, let me just add one more thing. Back in the 1950s, we had a serious problem, a serious illness that principally caused harm to children. This was called rheumatic heart disease. Rheumatic heart disease vanished, probably because we overused antibiotics. We were told we oughtn't to be doing this, but the thing we oughtn't have been doing probably got rid of it. And when we had the large old mental hospitals, up to a quarter of the patients had a condition called catatonia, which has vanished. Probably because we were doing a thing we were told we shouldn't be doing, which is overusing benzodiazepines. Postpartum psychosis, the classic version of it, has now completely vanished. You can ask me about that claim later. Schizophrenia has decreased in frequency a lot, but you don't hear anyone asking about what's going on. We need to understand what's going on. It would be a way to get rid of these illnesses. Why isn't that happening? Well, it's not happening because, as we recognized around the time of World War I, and increasingly since, we used to make weapons in order to fight wars. We now fight wars in order to sell weapons. With the advent of the SSRIs, medicine changed. It used to be a case of we made treatments in order to fight diseases. We now sell diseases in order to, hang on, hopefully I've got that the right way around. We used to make treatments in order to fight diseases. We now make diseases in order to sell treatments. There's no one within healthcare, it's like the arms industry, there's no one within the healthcare that has an interest in you being healthy and disease and pill and treatment free. Something to bear in mind. Now, let me introduce you to something else. About 4 years ago, I was asked to review a paper for a journal called Social Science and Medicine. This is a very prestigious journal. And the article was written by two psychiatrists from the UK that psychologists over here think are wonderfully ethical and good, almost honorary psychologists. Their names were Joanna Moncrief and Mark Horowitz. And their article said, we know there's no evidence that there's anything wrong in the serotonin system of people who are depressed. But 29 of the 30 most cited articles in this area claim there is a problem in the serotonin system of people who are depressed. What's going on here? I was asked to review the article, and I told the editor that yes, they're right, there's nothing wrong with the serotonin system. We never thought there was anything wrong with the serotonin system in people who are depressed. But you could kill two birds with one stone here. You should invite the authors to say why 29 of the 30 articles claim there is a problem, because the answer is obvious. It's these articles are ghost-written. And the ghostwriters put this bit of marketing copy into their articles, and they each cite each other. That's why these articles get so cited. The response from the authors was, well, we're too nervous to say that. So the editor turned to me and she said, we really liked your review. We'd like to publish the original article and your review along with it. So could you add a few references in, and we'll do that. So I did exactly what I was told, added the references, and one sentence that I knew was going to discombobulate her so much she wouldn't publish. And the sentence was, what I've just said here about the SSRIs is true for the COVID vaccine trials also. They too are ghostwritten. There's no access to the data, and injured people have been made to disappear. Social Science and Medicine, who's the kind of journal you would figure has a lot of backbone, or should have a lot of backbone, didn't publish, simply because of that one sentence. Now, let me make it clear here. I've never called for any vaccines to be removed from the market. I've never called, I haven't been hinted to anyone that they shouldn't have a vaccine ever. I've never called for any drugs like the SSRIs to be removed from the market. My concern is the confidence we can have in the treatments that we're going to give, which are always risky. So, there's an issue about trying to handle the risk as well as the possible benefit. And back around that period of time, I'd had several friends. In fact, I know no one personally who's died from COVID. I'm probably a bit of a freak in that respect. I've got several friends, including co-authors on articles I've written, who have died from the vaccine. By that I mean a few days of having had the vaccine. I know I've got several friends who were so enthusiastic about the vaccines that they entered the trials of these vaccines and were injured and disappeared. I was working in a clinic in person, not virtually, through the pandemic. Everybody there had to be vaccinated. There were members of staff who were obviously seriously injured by the vaccine they were given, but their colleagues, their friends, lifelong friends, the doctors there insisted this couldn't be coming from the vaccine. They had to have the second shot. This is an extraordinary situation to be in. It left me thinking, when it comes to therapies, whether the psychotherapies, or the drug therapies, or the vaccines, or whatever, any aspect of healthcare, there were a little bit like a situation in Germany 80 years ago. A bunch of people were told, there's a fuss going on in Western Europe which we need to sort out. We'll just move you to work camps out east. We'll put you on trains and send you there. And lots of people felt this was pretty strange and probably not right. But somebody would recognize a mistake had been made and would put it right. After people came back from the work camps out east, a bunch of them thought they'd move to Israel, where they were not met with sympathy. The story now is awful sympathy the whole time. People were completely flooded with loads of sympathy. That's not what happened when they got there. They were met with, why didn't you resist? Most of us, if we're honest, are people who get on the train, and we don't resist. If you're going to resist, we've got to try and work out, what is it that we think isn't right? What is it that we're needing to resist? What's this milk of paradise stuff all about? Well, the little bit down the back, that's the steep ascent up to the Big Dip. When we got to the steep ascent up to the Big Dip, dead cool Greg in the seat beside me had become a gibbering wreck. And I still had no idea what was going to happen. And you don't have any idea where this talk is going either. So we have time in this slow bit of the Dipper to ask two questions. One, where did the SSRI group of drugs come from, and what do they do? Okay, the question about where the SSRIs come from, there's an interesting answer. It was a bunch of Freudian analysts who essentially discovered the SSRI group of drugs. They were there doing Freudian psychotherapy with the patients that they had. And some of these patients were also then put on antidepressants like imipramine. And the analysts could see them becoming suicidal, take the pill away, and that cleared up. They introduced the pill and the problem came back. So they figured, they came out clearly and said, look, these pills are great to have, but they can make you go out and commit suicide. The analysts could also see a bunch of fairly severely depressed patients who lose libido and lose the ability to make love. The analysts could also see that even though the drugs were being given to that kind of patient, that the drugs were also causing you to lose libido and be unable to make love. It's the kind of thing that doctors now giving SSRI drugs, which are even more likely to cause sexual problems than imipramine was, cannot see happening to healthy volunteers put on these drugs who have no sexual problems, no loss of libido, a terrible change when you get put on the pill, and doctors can't see it the way the analysts could. But the key thing about what the analysts saw was they said, these pills change the transference reaction in therapy. Not all of them, but some of them. And a man called Arvid Carlson was listening into this, and he said, well, that's very interesting. The ones you say change the transference reaction act in the serotonin system. The ones that don't change the transference reaction don't act in the serotonin system. So let's make a pure SSRI. This was long before Prozac. Prozac was the fifth SSRI. Okay, so he makes one, and it becomes clear that this change in the transference reaction is a reduction in emotional reactivity. Now, we'll go into that a bit more later. But first, I want to tell you, Carlson didn't think he was fixing anything in the serotonin system. He thought he was acting on a normal serotonin system the way LSD acts on a normal serotonin system. And just like LSD can give you a good trip or a bad trip, SSRIs can give you a good trip or a bad trip. If you asked Arvid Carlson, can you become suicidal if you have a bad trip on your drug? He said, yes, you can, absolutely. What he was making, the phrase he used for what he was making, and the phrase that's true for almost all the drugs we have, is he was making a therapeutic principle, something that might be helpful. And this is a slide about constipation. It's just to lighten the mood. There are 4 different therapeutic principles that can be used to treat constipation. You can add fluids, you can add bulk, you can stimulate the bowel, you can relax the bowel. Your great grandmothers and old-style family doctors were very good at working out what was the kind of laxative we should give you. Companies today who get approval from FDA to call their drug a laxative don't have any incentive to ensure that you get the right laxative, the right therapeutic principle for you. They don't mind if you're on 4 or 5 different laxatives, provided one of them is theirs, but this is the route to treatment-resistant constipation. Now, this scenario is true for treating diabetes, hypertension, cancer, almost every illness in medicine. There's a bunch of different approaches, pill approaches that can be used. The key thing is getting the right thing for you. It's true for depression. And SSRIs are one of the therapeutic principles, not the only one. Antidepressants don't all do the same thing. They do completely different things. SSRIs are one option, and if they're the wrong option for you, we recognize that they can cause treatment-resistant depression. And we have no idea how to cure this. An increasing number of young people are opting for euthanasia in their 20s as the only way out. So this is not irrelevant. I'm going to go on to the therapeutic principles behind other pills for nerves now in a moment, but let me just move to psychotherapy first. Freud began with a therapeutic principle which said, when people come in and talk to me about being abused sexually during childhood, believe them. And then one day in his clinic, a woman threw her arms around him, and he was slightly flummoxed and said, how am I going to explain this? And rather than pick the obvious explanation, he said, she's having a transference reaction. This meant that she's thinking, fantasizing in some way that he's her father, which of course meant that the father didn't sexually abuse her. And he began thinking that all of the sexual abuse cases that he thought were real weren't, that they were fantasy. So this was a different therapeutic principle. It's not one that helped Freud recognize real abuse when it was happening. Maybe not all cases are real. Certainly on the alien spaceship, they probably aren't, but it is a serious problem and does need handling. And Freud became rather poor at it from there on. But the pharmaceutical industry has looked at this and said, this is a wonderful therapeutic principle for us. What Freud's telling us, and we believe, and we're going to work on the basis of, is we all want a father figure. And we're going to beef our FDA up into the father figure that all of you want for these drugs. And that's what they've done. And they've created a situation where if FDA put a label on a drug saying it works, even women who are pregnant will take it, but they won't take anything else. They're doing it because their father has said this. This is what Freud would have called delegated narcissism. Narcissism, okay? And it applies to Woody. When Woody goes in a pill and says, this isn't suiting me, and starts rolling on the floor and holding his head and said, you wouldn't believe the thoughts going through my head, the response from doctors and everyone in healthcare, probably a lot of the public, is he's fantasizing. This is not what's really happening. Jung, looking at Freud, Carl Jung, said, that's crazy. You're applying one principle to everybody as though they're all the same, and they're not. We've got extroverts and we've got introverts. Extroverts, when they get anxious, spread the problem around. Introverts, when they get anxious, internalize it. Now, that probably sounds terribly mental to you guys, but in fact, if we gave you all a personality questionnaire that measured extroversion and introversion, we could use your degree of extroversion or introversion to predict how much anesthesia it would take to put you to sleep for surgery. Extroverts need much less than introverts. Woody was an extrovert. Extroverts respond poorly to SSRIs compared to introverts. Not all introverts are helped by SSRIs. Extroverts really aren't helped at all. Extroverts these days get labeled as having ADHD. Introverts get labeled as having ASD. We're pathologizing normal variation, and this is a disaster. We need different sets of skills. You're not going to have a good team, either a marriage or a job situation or a football team. On a football team, you need the guys who can score the goals. These days it's the girls, they play better football, who score the goals, and the ones who can make sure the other side don't score goals. They're two different sets of skills. We need to have a good team. So cognitive therapy, to some extent, has, I think, had problems because it tends to view all people as the same. My lady with, well, the one that I got vaguely involved in who was abused on the alien spaceship was an extrovert. Extroverts are much more likely to recover memories of abuse that never happened. If you're just in the business of believing patients and trying to handle them in a standard, logical way without recognizing there may be huge differences in the way they handle their anxieties, you're not going to necessarily get very far. Cognitive therapy, as you've heard from David, there's a number of different therapeutic principles in it. You can have cognitive restructuring, behavioral activation, problem solving. These are all different techniques, and maybe only one of them will suit. If CBT works for you, it may only be one bit of it that's working for you. The trouble is, a therapist sticking to the manual is going to fling them all at you, and that's not helpful. But here's the point. The one group of people who, took up Jung's ideas as well as Freud's, who took up the idea of therapeutic principles, even though that's not the way they sell drugs, was the pharmaceutical industry. They recognized that consumers are different. Broadly speaking, there's 4 different kinds of consumers who need 4 different therapeutic principles, a bit like constipation, except industry called them marketing principles. And what they mean by this is segmentation. They want to segment consumers and make sure each consumer gets the right marketing input for them. And of course, the consumers means doctors. You're not the consumers. There's 4 doctors, I believe, in the room here, roughly 200 people. It's this 4 may sound like a very small number of people to you, but you'd have to have 1,600 people in the room with 4 doctors here to have roughly the number of doctors for the population of the United States. To be able to get something that's roughly the same comparatively. And there's more money being spent on those 4 doctors and 1,600 out of 1,600 people here on shaping their minds than are spent on the other 1,596 consumers of you with all the products you buy. There's more marketing dollars just going into those four people who are the key consumers for the most profitable industry in the United States. And the industry view is they're aiming at ensuring that no doctor in the United States has a thought in his or her head that's not put there by them. So there's Farouz and me and two other people here who are being well looked after. It's not money being handed over. The money is being put into creating the evidence, because we say we're not influenced by money. We're influenced by the evidence in the New England Journal of Medicine and JAMA. And industry target the very best journals because peripheral journals are no use to them. So let me take you back to the therapeutic principles for nervous problems. You might think, well, okay, he's saying these drugs don't fix problems, but they still go to the brain, don't they? And the answer is no. If you look at a benzodiazepine, this is a drug that can make you less anxious. It relaxes your muscles. And your brain is fooled into thinking, well, his muscles aren't tense, so he can't be anxious. If you look at a beta-blocking drug, these are drugs that slow your heart rate and are used to treat people who are anxious. And if I'm on a beta blocker and I'm here giving you this talk and my heart rate's going very slowly, my brain will be saying, well, he must be fairly relaxed here. He can't be anxious. I am anxious. But anyway, he really can't be anxious. So the brain, again, is being fooled. There's another treatment that I'm going to bring you to before the exercise. It's nicotine. And here's the story. SSRIs reduce emotional reactivity. Now, I'm obviously going to tell you they work in the body, not the brain. But before we get there, they reduce emotional reactivity. And this is better for people with OCD than people who are depressed. Arvid Carlson didn't treat people, but he did listen to clinical colleagues like the analysts. That's where the SSRI idea came from. Oh, I forgot to tell you, listening to analysts, I don't think I mentioned this, Arvid Carlson, who was a pharmacologist, listening to the analysts back in the 1960s said, you know, the drugs you said, I did say this, didn't I? The drugs that are working on the serotonin system are the ones that reduce emotional reaction, or change the transference reaction. But I don't think I mentioned his name, did I? Anyway, well, Arvid Carlson was there happily thinking SSRIs are very good for OCD when one of his clinical colleagues came to him one day and said, look, I've got a bunch of patients who tell me that smoking nicotine is better for their OCD than your SSRIs. And Carlson said, okay, let's run a trial and see. And they ran a trial, and the conclusion was for many people who are anxious, not just people with OCD, nicotine can be much better than SSRIs. Now, there's a few points I want to make here. One is, if you've got OCD or if you're anxious, who is the best? Who should actually decide whether you smoke nicotine or take snuff or take an SSRI? Is it FDA? Is it your, who haven't licensed nicotine for this purpose? Is it your doctor or is it you? And I would argue, really, only you can know what good, if any, the nicotine does for you, what good, if any, the SSRI does for you. You know the risks to nicotine. You may not know the risks of SSRIs. They cause you to die prematurely, just the way nicotine does. He loses many years of life with SSRIs as you do with nicotine. Now, I'm not trying to advocate nicotine here. My father died from lung cancer because he smoked heavily. The fathers of lots of my friends died from either heart attacks or lung cancer because they smoked. So I'm not in the business of trying to advocate nicotine here. What I'm trying to get at is this. When I began practicing medicine, it was commonplace to hear or to say, the art of medicine involves bringing good out of the use of a poison. If I say that to audiences now today, particularly a more liberal elite type audience, they hold a crucifix and garlic up in front of me and they hiss. If you introduce the word nicotine into the frame, they get the point. They say, well, yes, that is a poison, and oh, yeah, maybe you can bring some good out of it. But what I'm getting at really here is there's been a change. fundamental change from seeing everything as being like nicotine potentially hazardous to one where we've got the SSRIs and all these drugs which we can't even begin to think could be hazardous. What do the SSRIs do? Well, 5% of the serotonin in you and me is in our brains. 95% is in the rest of your body. It's in the sensory receptors in your peripheral nervous system. And LSD works on these things as well. It isn't particularly working on your brain. The sensory receptors are in your eyes, obviously, and your vestibules in your ears, and in your joints and muscles, and in particular in your, well, you've heard about your gut, I think, but your gut is outside your body, you know that. It's continuous with your skin. It's a tube that's not inside you. It's continuous with your skin, and between the gut and your skin, that's the biggest organ in your body. And that and your eyes and vestibules are your boundary between you and the world. It's not your brain. It's these sensory receptors are the bit of us that does what Daniel Kahneman called our fast thinking. We've also got a slow thinking, the executive function, which supports choice and things like that, which often gets things wrong. But the fast thinking is what mostly keeps us alive. And what LSD does is it opens the sensory gates and floods us with a ton of sensory images and things like this, so much so that the brain can't even begin to handle it. And we can end up thinking we've met God, we've seen the afterlife, we've witnessed what we're inclined to figure is our Aztec, our Jewish, our Irish ancestors being traumatized, and that's affecting us now. If you close the sensory gates, as you can do in a sleep deprivation tank, or with SSRIs, and the single commonest thing an SSRI does that many people can notice, but not all, is within 30 minutes of your first pill, your genitals will become numb. This is not happening through your brain. If you mute these things, you don't have a flood of images into the brain, you've got a trickle. You end up potentially being captured by a dominant image or two. If we mute you too much, if we mute you to just the right extent, things can be fine, maybe. But if we mute you too much, you can be captured by a dominant image, like hypnosis in essence. And you end up, I've ended up, you won't end up all that quickly, meeting people who've done some awful things, who shot up places and killed people, who've killed their 3 children, who've killed their wives or their husbands or whatever. And you ask them, why did this happen? And often they'll say, I don't know. I just had a thought there. I felt compelled to do it. I don't know why I didn't choose not to. I've had these thoughts before and I was able to choose not to. I just ended up doing it, and I really don't know, which legally doesn't work terribly well for people, but this is what this group of drugs do. So that's where the SSRIs work, and it's in the body, and this feeds your brain. If there's less stuff going in, I mean, if you've got more and more stuff going in, you're forced to be more vigilant. If you've less and less, you think there's not much going on around there. And hopefully, if you don't have the wrong dominant image, you'll be reasonably relaxed. But if you do have the wrong dominant image, you're in trouble. Now, I should have moved the slide on to, I've done the wrong thing here, to this one. Yeah. Unlike LSD, which you take and lasts for 12 hours or so, and you don't take it every single day of the week, or you don't top up the dose once the previous dose has worn off, your serotonin system can recover. If you put on SSRIs in essentially toxic doses, these were never brought on the market at low doses. The doses you've seen from the start were really way over what was needed. So if you're on these drugs for months or years in toxic doses, you can potentially break your serotonin system. And when that happens, people regularly complain about brain fog. There's bits of them that are just not working right. It can be their vision, it can be their touch, it It can be their inability to make love ever again, even though they're off the drug. And they complain about brain fog. And that leaves people thinking, my problem is in my brain. I've got a broken brain. But it's not. The problem is in the kind of knowledge we embody. And that can't be put right by concentration and attention. But trying to concentrate on how to play the piano when you used to be able to play it well, but your SSRI has ruined your joint sense, so things aren't working out. Trying to concentrate and put it right with cognitive effort is what leads to you feeling brain fog. When we test your brain, there's nothing wrong with it. The answer is a little bit the way kids here, any of you've got young children or can see young children around the place, just about when they're learning to walk, they pull themselves up and fall over again and again and again until they get it right. And then they may go to nursery and get a dose of a virus of some sort, and they're knocked off their feet again. They've lost the skill again. And the only way to restore it is not with Google or concentrating on what they're doing. It's just repeated effort again, really embodying things. Now, there's an interesting point here, which is there's a form of psychotherapy called interoceptive exposure therapy that David helped to introduce me to. And this is where you've got a bunch of therapists getting people to focus on their body, on what is increasingly called in the literature on material me. Getting you to focus on your body and becoming aware of it and things you can do to tweak how it's working rather than thinking this is the problem I've got to solve with my brain. And there are certain problems SSRIs cause that this can help. The problem, though, anyone trying to do this, either on their own or with a therapist, is you've got to be part of a team or some kind of situation where there's someone else giving your patients an antipsychotic, which can do the same kind of thing, or an SSRI, and they're essentially pouring oil on the flames you're trying to put out. So at the moment, this hasn't caught on, and as things stand, is not likely to catch on terribly quickly, which is unfortunate because I think it's got considerable potential. Now, just before you have your peak experience, this is the top of the ride. I'm going to tell you about one little thing. A bunch of us had this idea about testing out Albert Carlson's idea. Was he right that people taking an SSRI have a different thing happen to them that might be useful compared with people taking non-SSRI drugs? So we had 20 doctors and nurses working in the unit that I was in who volunteered to get involved in this, taking one of the two drugs blindly and then being swapped over to the other drug. In each case, they were on it for 2 weeks. The idea was, could they distinguish between the two drugs and could they pick out this altered transference reaction? And the answer was yes, they could. And the second interesting answer was that two of the people taking Zoloft, which was the drug we used, Woody's drug, two of the people taking Zoloft became suicidal, pretty seriously so. One was very close to killing herself. And Pfizer, in 1983, had run a trial of Zoloft in healthy volunteers, where every single one of the female volunteers, I mean, this was all the volunteers, it was actually done only among women, all of them dropped out after 4 days because the effects of Zoloft were agitating and intolerable. And Pfizer had written, and I have to document and give it to you, Zoloft can cause this. Now, the third most interesting thing, and this will lead you to the edge of the drop. None of the patients in the unit knew this was going on. One of them came up to me after 48 hours and said, "Is Dr. X on a drug?" I said, "Yes, he is," because I knew he was on a drug. I didn't know which one. So the patient said, "Is he on an SSRI?" And I said, "I don't know, but when we break the blind, I'll be able to let you know." And when we broke the blind, the patient was right. And what the message is here is that patients are much more expert looking at what's going on with drugs than healthcare staff. Doctors, nurses, psychologists, or anyone, they can spot when you go on an SSRI within 24 hours. Your family and friends can spot it as well, but you're told this is irrelevant, the drugs take 6 weeks to work. doctors and therapists can't spot it, even though this is the reason we have SSRIs. This is where they came from, because therapists could spot it. This leads into a further issue, which is going to be part of the peak experience. When I say peak, you probably imagine P-E-A-K, and you're sitting on a mountaintop and able to survey all around you, like the mountains here. I mean P-E-E-K, where you're peeking through those fingers at a problem you hope is not there. And the problem is this. The problem for Woody, for you, and for all of us is we're dealing with religion, not science. We're dealing with doctors. Woody had a good doctor called Dr. Armstrong, who, like all good doctors these days, follows the standards of care, the guidelines, the evidence in the best journals. Following something is a religious act. Science starts when I put a pill in your mouth, someone puts a pill in your mouth, you put a pill in your mouth, and we're in the business of trying to work out what is happening from there. The experiment starts there. We don't know what's going to happen when you do this, and there's not something to follow. There may be things in books which may be useful, but real life is what's happening to you. Now, religions, we change from trying to make ourselves holy to making ourselves healthy. But whether it's about making you holy or making you healthy, religions are about keeping the tribe together. And it's done with slogans like CBT versus SSRIs, Catholics versus Protestants or whatever. This is what religions are primarily about. These days we confess our ADHD and ASD the way we used to confess our sins and are saved. People appreciate, they almost applaud you when you confess the original flaw in you. Religions, in religious systems, abuses happen, and we know that. But there's something that holds us in there despite the abuses we know that are going on. And it's because religions have some magic principles. In the case of healthcare, we've borrowed two from the Catholic Church, and these are sacraments and infallibility. A sacrament is something that can only do good. It's just the opposite to a poison. The church has had to face the fact that, there's gluten in what we're calling the real body and blood of Christ, and this gluten can harm people. So the Eucharist is not quite the sacrament that it used to be, but our meds have become more and more sacramental the whole time. And the principle that makes them sacraments is the milk of paradise. It's randomized controlled trials, which emphasize the benefit and hide the harms, the best method ever discovered to hide harms. Let me explain. The story, how this actually happened, began 35 years ago when three Boston clinicians had 6 patients who became suicidal on Prozac. And they wrote it up, and within a year, there was 20 other groups from Yale. Yale and Harvard were saying the same thing on this one, were saying, yes, we've seen the same thing too. So, and these were all articles in reasonably good journals. There was no doubt Prozac could cause some people to commit suicide. The response from Eli Lilly, the makers of Prozac, was to say, well, we've analyzed our RCTs, and they show no evidence of Prozac causing people to commit suicide. Now, in actual fact, when you get hold of Lilly's RCTs, you can see there was tons of evidence of people becoming suicidal on Prozac. But the headline was, there's no evidence of RCTs of Prozac causing people to commit suicide. And they branded RCTs as the science of cause and effect. And they branded your view that, in say, the case of Kim and Woody, that view as the idea that Zoloft had made Woody, well, in this case, Woody Prozac had made Woody suicidal, was an anecdote. This is where the word comes from. We now use the word misinformation, perhaps, instead. Now, this is extraordinary, if you think about it. If you're a jury in a murder trial, a man has killed his wife, and you've been asked to give a verdict on whether he murdered her or not, and his lawyer got up and said to you, look, All our RCTs and epidemiology show that on average, men, even men with a criminal record, even men with legal and financial problems, even men with wives that no one likes, don't on average murder them. So you cannot find him guilty. You'd say, that's crazy. Give us the details of this case, and we'll see if we can get a consensus that he is or isn't guilty of murder. This is the same situation we've got with all of the harms on antidepressants and any drug in the rest of medicine. You want to, on the basis of an individual case, you want a group of people to come to consensus as to whether the drug in this case has shown that it has the capacity in some people to cause problems like this. It may not do it on average, but the question is, does it have the capacity to do so? And part of the reason Lilly were able to succeed is that RCTs are an averaging machine. Lots of people end up saying they only work by placebo because, if you take the good effects in some people and the bad effects on others, a bit like LSD, you could turn LSD into a placebo if you just averaged all of the good and the bad effects out. But that's not what happens with SSRIs. I guess the key question is, if what I'm saying is true, there's good effects there and bad effects. How many people have the good effect and how many people have the bad effect? Well, FDA data is fairly clear on all this. 50% of the trials done on FDA, on the antidepressants, on the SSRIs in particular, are negative. They can't show any benefit with them. So not all of those people are having a bad trip, but it means that there's a significant proportion of the people who get put on these drugs, maybe a quarter of them are having a distinctly bad trip. When the drugs came out first, before doctors were trained to say these things take 6 weeks to work, they didn't say that kind of thing to patients, and all of the studies that were done during the first year or two when the drugs came out showed that 50% of us stopped them within a month. We may not have had a terribly bad trip, but we certainly weren't having a good trip. Approved by FDA suggests to most doctors and to most of us that we will have a good trip on these things. FDA have 100,000 people from the clinical trials done on these drugs. And when they look closely at the group of trials that they used to license the SSRIs, and look at the ones who are having a good response that's totally different to the placebo effect, that's way beyond anything you get with a placebo, they end up concluding that 1 in 6 of you might get a good trip from an SSRI. And most doctors give you these drugs hoping to give you a good trip, and you go in maybe even asking for them, hoping to get a good trip. Well, the chances of you getting a good trip are about 1 in 6. Okay, there's a proposal when Zoloft got licensed. You didn't see at the slide David put up that technically you've got to have 2 trials to get an FDA license for a drug. And technically, Zoloft didn't meet those 2 trials. It didn't even have 2 positive trials. And this caused a lot of debate within FDA. And there was a proposal, we really should include in the label of the drug the number of negative trials there were. And in FDA at the time, and until the end of last year, the real boss in FDA was a guy called Bob Temple. He's what you could call an eminence grise. And he nixed that idea. No, we're not putting into the label of the drug that there were all these negative trials. FDA, back then, in 1991, when Zoloft was being licensed, knew there was only a very small number of people on any of these SSRIs that would have a really good trip. But there's no hint from the label of the drug that that was the state of play. So in terms of people saying the effects of these drugs are just placebo, one of the hazards with all that is you cause most people looking at Woody having the bad experience he had, lying on the floor, and they're thinking this is really a fantasy, partly because if it's just a placebo, if there's all these experts saying it's just placebo, well, the drug couldn't be causing him to behave like this. There must be something about Woody, his illness or whatever, that's causing this. You have to be told the drug can cause serious outcomes like this to be able to see them happening in the person in front of you. So, yes, where am I going with this? I'm making progress, but I need to remind myself. Oh, yeah, okay. Right, yeah, now, not all of you here, I guess, do science, so I hope you don't have a near-death experience when I give you some figures. These have been made very simple. They're rounded up, as you see, and they hold true not just for SSRIs and treating people who are depressed, they hold true for antihypertensives, anti-diabetic drugs, painkillers, chemotherapies for cancer. You're told by the popes and the cardinals of evidence-based medicine that RCTs are magic. They control for all confounders in the known universe. So this means that we get objective and reliable knowledge out of them. But they don't control for the elephant in the room, the main confounder, which is our ignorance. They can't control for this. And the ignorant bit is depression is 20 or 30 different conditions. Dementia is 20 or 30 different conditions. Parkinson's is 20 or 30 different conditions. Back pain is a lot of different conditions. And if you've got different conditions responding differently to different therapeutic principles, if you're clever enough, and this isn't knowing things, it's just being streetwise, you can use the problem a drug causes to hide the problem the drug causes. And this is a great example of it. Up there on top, you've got a huge SSRI trial, and you guys looking at it and looking at the 10 suicidal events in that trial would say, all things being equal, you prefer placebo to the SSRI. In the next bunch of lines there, it's a much smaller trial, but much more suicidal events. And still, the SSRI looks worse, and you say, well, I don't think I want any option here, but if you're forced to take one, you'll take the placebo. Now, if we just simply add those lines together to get what you've got here on the bottom, all of a sudden, if you do the math on it, you'll say, well, I'm not sure I want either, but technically the safer drug is the SSRI. How does that happen? Well, that's what randomized controlled trials do. They do not give you reliable and objective information. This isn't just an abstract idea. This is a trick GSK played in FDA. When there was a fuss about SSRIs and suicide in adults in 2006. That's the GSK document up there. You're not going to be able to read it. The bottom bit in bold gives you roughly what I put on the previous slide. The only thing I want you to look at in this slide is this column here on the right, which says OR, 95% confidence interval. These are the statistical tests. And this is what makes companies and FDA infallible in their knowledge about drugs. And FDA will say to you, well, look, we don't have sound knowledge that Prozac or SSRIs can cause people to commit suicide. And you ask them, why not? In essence, the answer boils down to, well, in this 100-chambered gun, there's only bullets in 94, and we only make statements when there's 95 bullets in the gun, so we're not prepared to say the gun is loaded. Now, that's a use of statistical significance that medical statisticians have said to FDA and companies, this is nuts. It just doesn't apply to medicine. And they said you should be using confidence intervals instead. And here's a confidence interval. GSK's data on the previous slide for major depressive disorder has been drawn in the form of a confidence interval, the red line up there. And you see a black line down the middle. That's the 1.0 line. Everything to the right-hand side of that says the gun is loaded. Everything to the left-hand side says the gun is not loaded. And that teeny little bit on the left-hand side is the evidence that GSK and FDA would use to say the gun's not loaded. Actually, I should have told you that the figures in the GSK documents sent to FDA are ones that, having looked at the background data, I think are wrong. GSK have tweaked the figures, so there's that little bit on the left-hand side of the line. Okay, so the story about confidence intervals is this. We developed them when we had poor telescopes 200 years ago. And people were unsure whether they were seeing 1 star or 2 stars. And the idea was if you increase the number of measurements, the band that you've got will tighten up. And you can say that every measurement that falls inside this band means you've got 1 star, and a measurement that falls out here means you've got 2 stars. So that's fine, but it doesn't apply to human beings, and GSK have just shown you something that's not in any of the statistical books you'll find anywhere. They've added a few more measurements in, as you saw in the previous slides. And the confidence interval band has tightened up, exactly as theory says, but it should be tightening up underneath the red point so that you come to a clearer conclusion that the gun is loaded. GSK have now produced a situation where they can say, you know, you can leave the safety catch off this gun, you can leave it out of the gun cabinet lying around the house, and it isn't going to kill your kids. So the man there on the right is Ian Hudson, GSK's chief safety officer, in a trial that happened when a man called Don Shell was put on Paxil for a few nights' poor sleep, a bit like Woody. And 48 hours later, he shot his wife, he shot his daughter, he shot his wife, shot his daughter, shot his granddaughter, and himself. And a jury in Wyoming were asked to come to a consensus. And this man, Ian Hudson, we call him Cardinal Hudson because it's a church. We're talking about a religion here, remember? Okay. So he tells the jury, look, GSK practice RCTs and evidence-based medicine, and there is no evidence that Paxil causes any side effects. Forget suicide, it causes no side effects. And the jury look at him and figure he's crazy. And they decide that Don Shell did not murder his family and was not responsible for the deaths of his family. Paxil and GSK were. Now, Cardinal Ian Hudson, a short while later, was made Pope Ian as the head of Britain's FDA. So the kind of thinking you've seen here is at the top of our healthcare Vaticans across the Western world. Here's another slide. This is from a Zoloft trial in 1983. 1983, remember the date? Zoloft gets launched about 8 years later. This is one of the first trials they did. This is a man who's depressed and is put on Zoloft. And the rating scales say he's doing awfully well. He's going to be a success. He's going to be a good trip guy until someone who's talked to him before, maybe casually, senses there's something not quite right and talks to him again. It's not using a rating scale. He finds that the guy is thinking about killing others and then killing himself. He's had a few nights of poor sleep. He's dropped out of the trial, coded as nausea. There's no way FDA are going to be able to get hold of what really went on here. There are other people who dropped out of Pfizer trials as burns when they become terribly agitated on the drug, poured gasoline over themselves, set fire to it, and died in hospital from burns 5 days later. And they appear in the record as death by burns. So this is the kind of thing we're dealing with. And we're in the concluding bit now. You'll be pleased to know, you must all know, these are the witches from Macbeth. And Macbeth is a tragedy. This means that there's a flaw in the central figure, the hero, which is his undoing. Now, before I go on to take Macbeth bit further, I need to introduce you to a man called Austin Bradford Hill, who created randomized controlled trials. And 20 years after he did so, after he did the first one, 20 years after he did so, he was giving a talk to doctors, and he said, you know, randomized controlled trials tell me nothing about how to treat the patient in front of me. A good interview is much better. If we ever got to thinking randomized controlled trials were the only way to evaluate a drug, we would have gone stark raving mad. This is the man who created them. And you realize that, actually, to paraphrase what he said, and I missed something earlier that I should have mentioned. When I was talking about therapeutic principles in CBT and things like that, I meant to add in a provocative note for David, which is the lines of the art of medicine is bringing good out of the use of a poison. Other people have used the same thing to say all screening's dangerous, but some of it, if we're careful, can be useful. Austin Bradford Hill would have said, RCTs are dangerous. They generate ignorance. And unless we're very careful, we're going to degrade our treatment if we depend on RCTs. But the other thing would have been to say, psychotherapy involves brainwashing. We've got to be very careful about what we're doing. Okay? So anyway, Macbeth, RCTs have been the milk of paradise that's transformed our drugs into sacraments. They've transformed medicine from something where we used to make treatments to help with our healthcare needs into companies producing treatments to cater for our wants, for our discontents, for our first world discontents. There's been a conversion of medicine into trans medicine and a conversion of our drugs into puberty blockers. Now, where does this leave us? I'll have to check my notes to see where it leaves us. What we're looking at here, for those of you who aren't in the sciences, what we're looking at here is what the ancient Greeks would have recognized very quickly as the art of rhetoric, the art of persuasion, the art of marketing. We're not dealing with big pharma who's making drugs for our needs. We're dealing with big propaganda who are exploiting our wants, who are tempting us, to use a religious word. Who's going to solve the problem? Well, I don't think doctors are. We make a living out of dishing out these drugs. A prescription only is a police function. It's not actually part of medicine. It's what makes you feel when you go to a doctor that you're a little bit like an addict, putting in any request that he or she might not approve of. If you can get things over the counter, you don't feel that way. It's a completely different scenario. But if these drugs are 100% effective and safe, there's no reason why we should have expensive prescribers. And doctors are increasingly been replaced by cheaper prescribers like nurses. But they're sleepwalking into oblivion. They haven't woken up and said, hey, we need to emphasize the fact that it needs expertise to manage these dangerous chemicals. So FDA, industry have been very good at using FDA, saying they've approved the drug, they're the experts rather than your doctor. And a lot of doctors believe that now. They defer to a bunch of bureaucrats in FDA. And the difference between FDA and FAA, the Federal Aviation Authority, is FAA approved the plans to get from Boeing, okay? They don't keep you safe. The pilot in the plane keeps you safe. And she has an incentive to keep you safe because if you die on the way to New York, she's likely to die as well. Doctors don't have the same incentive to keep you safe. If you're on a healthcare plane these days and the door blows off it, you're liable to be thrown out the open door for spreading misinformation. So if you get put on a prescription drug, bring a parachute, is my advice. There is one other group of people who, this may actually surprise you, but who have an incentive to make sure the treatments work. We usually think of the free market as bringing new and good treatments on the market, and this is helpful, it moves things forward. Or we think of maybe social forces, education, research, and things like that are useful things too. And health has been a trump card for the left. That's an odd way to put a trump card for the left, but anyway, for a long time. But anyway, in actual fact, the biggest contributors to modern medicine have been the military, and in particular the US military. From the point of the US military has an incentive to have more Americans and more Americans healthier. And they're now faced with a situation where life expectancy in the United States is plummeting. The reproductive replacement rate has gone down. The disability rate's going through the roof. This is not a good situation for the US military to be in and they have an incentive to maybe get to grips with the situation that we've now got, because they can be replaced by the Chinese military unless they get things right. Getting things right is not about making more money for shareholders. It's looking at their strategic interests. So I think it's not impossible that the military, and this may be what the current Trump government have been saying to us, that the military will have an incentive to chop down Burnham Wood, check where Dunsinane is on Google Maps, and head that way. But, okay, so when they get to Dunsinane Castle and Macbeth is there looking at Burnham Wood, remember, he's been told by the witches, you're safe until Burnham Wood moves to Dunsinane. As Lilly and Pfizer have been told by the witches, you're safe while everybody believes that RCTs are gold. So when Macduff and the army he's with get to Dunsinane, and Macbeth is confronted with Macduff, he says arrogantly, it's no problem, no man born of woman can harm me. And he hears a growl in response, which says, I was from my mother's womb untimely ripped. In this case, you've got Kim Witzak. You don't need to be a man, and you don't need to be wielding a sword to do this. You've got Kim Witzak facing down the equivalent, in a sense, of Macbeth, which is Bob Temple within FDA, and explaining about Woody's case and what happened. And Temple responds with a word that he knows will be insulting. He says, Woody was an anecdote. And Kim has produced a badge, and we've got a bunch of these badges, which she's got, which she's going to leave up here after I get off the stage soon, saying we are not anecdotes. That's been the response, the badge that she's campaigned under for the last 20 years since Woody's death. You've got a thing that you can put on T-shirts. She's got a thing that you can put on T-shirts and things like that. And we need a bunch of you to say we are not anecdotes. Well, what are you? When the Prozac suicides happened, the guys who actually produced the reports produced what journals called case reports, which Lilly rebranded as anecdotes. I better not flick to the last slide just yet. I'm getting... Okay, so let's take you into a room in London in 1660. 54 years early, in 1606, Macbeth has been played for the first time on a stage in London. Less than a mile away, there's a room in which a bunch of men meet. At this point in history, it was all men, and they created science. What do I mean? Well, they ran experiments in front of a bunch of observers who were invited in to the event, the single event, which was going to produce observables. And what the observers had to do was to come to a consensus about what they were seeing. The experiments were like transfusing blood from a young and healthy dog into an older, frailer dog, and seeing the older, frailer dog actually becoming healthier looking and things like that. Looking down what we now call a microscope and seeing for the first time tiny little animals that they called microbes, which we now call germs, for the first time, and tried to work out what on earth, what have we seen? Are we sure we've seen these little things? And what does it mean? And this got written up in what were called case reports. It's a report about an event. At that point, we were 200 years away from having any medical journals. We were 300 years away from any statistics being used in clinical trials. We had the 1950s, which was the decade that produced more new drugs than we've ever had before, and good drugs. It created most of the classes of drugs we had and created the best in class. Some of the drugs are still the very best in class, all without a single RCT. Because to bring drugs like this in the market, you had a doctor giving them to you, and both you and the doctor could see the benefit, which you can't see in SSRI trials. It's just a statistical mirage. So anyway, we're going to bring Kim and Woody into the room. And we're going to bring Woody's mother into the room. He'd told her that he was very worried about the way he was thinking. He was worried he might harm Kim. This was after he'd had a few nights poor sleep and was put on Zoloft. A bit like Don Shell, a bit like a man in Sydney, Australia, called David Hawkins, who was put on Zoloft, and 24 hours later, he was put on it for a few nights poor sleep, and 24 hours later killed his wife. And the prosecutor and the judge in the case said, we don't need to go to a jury. It's clear Zoloft caused this. And Pfizer, if you remember, had the clinical trials and the healthy volunteer trials, which showed they knew this could happen. Okay, so we'll bring Pfizer into the room as well. We'll bring someone into the room who has a good response to Zoloft. We'll bring Chris Armstrong, Woody's doctor, in. We'll bring Bob Temple in. And the challenge is to come to a consensus about what happened here. That's what science is about. When you bring an adverse effect, when you've gone on a pill and you bring an adverse effect to a doctor, it's about an analysis of an experiment that's taking place. And he's got a bias, which is that he doesn't want to think he's harmed you. But you're trying to come to a consensus. Now, a good doctor like Chris Armstrong, he was a decent doctor. And lots of other good doctors will say, you asked me to do science. I'm not a scientist. I'm in this business to care for people. My suggestion is that the answer to that is, well, if you're not willing to try and believe me, to listen to me, to come to a consensus with me, if by a consensus you mean I have to accept some belief you had before I walked into the room, then I don't think you can care for me. So let me just give you one example, one pointer to how badly wrong we've got. Let's say in our room with Bob Temple, we come to consensus, Zoloft killed Woody or whatever, and we wrote that up as people did in 1660 in the Royal Society when they were creating science, and sent it to a medical journal. No medical journal would take it. I will believe that Burnham Wood has moved to Dunsinane when the New England Journal of Medicine publishes adverse event case reports. Not before. My hunch is the best option going forward is for an accidental spilling of some water on the editors of our medical journals that has the same effect as it had that it had on the Wicked Witch of the West in Over the Rainbow, or whatever the thing is. That's the situation we're in. It's a grim one. Now, we're talking science, and I'm about to end on the last point. We've done all the science. I'm just going to give you one last thought, which is we can't bring a ghost into the room. Actually, it's not showing fully. You're missing a bit there, which is a pity. That's Woody. But let's say he could appear in the room like Hamlet's father's ghost appeared and told Hamlet about, how lying, he had been poisoned. Lying down, he'd been poisoned. And he wasn't poisoned by a pill put in his mouth. The poison that killed him was fed into his ear. It's what you're listening to. It's the AI and things like that, which is, up to this, David and Kim and others here, we've all been faced with big propaganda. What I meant to mention is the younger generation here with AI are faced with total propaganda. Okay, so Hamlet's response to the ghost telling him what had happened was to say, on swift wings he would fly to his father's revenge. But it's not what he did. He ended up being indecisive and saying, the time is out of joint. O cursed spite that ever I was born to put it right. This was the flaw in Hamlet that made Hamlet a tragedy. This is also our story. Thank you.